I think it's recording, right?
Yes.
Okay, go ahead, Dr. Siddiqui.
Okay. So can you see my screen here?
Yes.
Okay, great. So I'm going to present a few cases in brain radiosurgery. And as Dr. Sun mentioned, please feel free to put your questions in the chat during the presentation. And we have a moderator who can help um, interrupt the presentation and ask, or at the end of the case, at the end of each case, I'll pause to see if anybody has any questions. And the three cases we'll be doing today, one of are two cases of brain metastases and one case of a skull-based benign tumor. Obviously, brain radiosurgery has many, many indications, but these are the most common two things that we see in our clinic and probably most commonly treated worldwide with radiosurgery. So the definition I like of radiosurgery is whenever we're using an ablative technique causing an injury to a small region with high precision with a large dose of radiation. And whenever we have a patient who comes to my clinic to consider radiosurgery, we always start by considering alternatives. Does this patient need surgery instead? Does the patient need IMRT or fractionated radiation instead? Or no treatment at all, as we'll see in some cases. I think the number one sort of falling point or place where we can mess up is if we don't have a good MRI. A good MRI is very important for evaluating the patient, and it's very important for planning the treatment as well. So different centers, including the two centers that I've worked in as an attending, have different standard protocols for how to get an MRI. For the purpose of radiosurgery, there's essentially two protocols that are most important, and that is T1 contrast and T2 without contrast. So we don't care a lot about diffusion. We don't care a lot about ADC and SWI and all these other sequences, or even FLAIR, to be honest. But T1 contrast and T2 are critically important. There are many studies on which kind of T1 contrast MRI is best for radiosurgery. There's no one good answer, but I will say that depending on whether you have GE or Siemens or another scan, these names will differ greatly. For us, we have a Siemens scanner, so we use the technical term MP-RAGE. GE uses Bravo. Other companies may use other scans, but the important things are that they have magnetization preparation. So they do a special sequence of how they magnetize the field to enhance contrast and enhance the difference between white and gray matter. And I can point this out a little bit when we review the cases, but it's very helpful when planning. You can use other types of T1 post-contrast high-resolution sequence like the space sequence, spoil gradient sequence, but they don't have quite as sharp of a delineation compared to these magnetization preparation sequences, which is so-called MP. Now, when we go to T2, T2 is not as critical for every case, but there are many radiosurgery cases, including benign cases or brain metastases cavity cases that require T2 for good planning. I think you can get away with a plan with a very good T1 sequence with contrast, but T2 adds an additional element. So for the first case, we have a 78-year-old male with no history of cancer who presents with gait imbalance, vomiting, and headache. And so the first thing to consider when you see the MRI is that there's a very large, approximately 5-centimeter cystic lesion in the right cerebellum, which explains the symptoms. And so the first thing, again, that I consider is this person appropriate for radiosurgery? And if everybody can take a moment to think about it, well, there's certain things that are missing here. Number one, we don't know his diagnosis. And I think anytime you're treating a patient for tumor or cancer, we really want to make sure we have as much information about the diagnosis as possible. Secondly, even if we knew that this was cancer or brain metastasis, this tumor is very large. A 5 centimeter lesion is not really appropriate for radiosurgery. So the first thing I'm thinking about is, can the neurosurgeon resect this lesion? And if neurosurgery cannot resect this lesion, potentially there's a different technique apart from radiosurgery. I will say all the inclusion criteria on major trials require that the target be less than 4 centimeters for a good radiosurgery case. And case by case, you can go more than 4 centimeters in diameter, but all the North American trials require 4 centimeters or less as the maximum diameter. In this particular case, because we did not have pathology, the patient was severely symptomatic as well, we opted for neurosurgery to assess the patient. Even if this lesion was less than 4 centimeters, if it's causing a lot of mass effect in the brain, we do want to refer to neurosurgery, to our neurosurgery colleagues for resection. So it could, because even a 2, 3, or 4 centimeter lesion can cause a lot of edema, a lot of mass effect, and starting with radiosurgery may not be appropriate for the patient. So the patient had a resection confirming adenocarcinoma, likely of lung origin. And there's a post-op day 1 scan that is commonly done. Now, it's not required to do a post-op day 1 scan for brain metastases, but it is commonly done in some of our hospitals. And a preliminary diagnosis is made of adenocarcinoma. Usually, as a radiation oncologist, I get informed of this patient at this point. It's easy to bring the patient in for planning right away within a couple of days of surgery if you have an inpatient center. Oftentimes, the patient does need a few days to recuperate and be discharged to an outpatient setting so that they're no longer admitted in a bed in the hospital. Even if your radiation center is in the hospital and you are able to transport inpatient patients who are in the hospital bed, it is important to wait after a brain resection. And that's for a couple reasons. Number one, the cavity is very dynamic after a brain surgery. In the first few days, that cavity shape will change very quickly. So especially with the LINAC-based approach that we're talking about today, which may take a couple of days to plan, if you start to plan the case within a couple of days of the surgery, by the time you deliver the plan, the cavity shape may be different. Secondly, our neurosurgical colleagues prefer that there's some amount of healing that is done, especially if we talk about this the approach area. So the subcutaneous tissue, the dura, and whatever they use to seal the brain has a chance to heal. And usually that healing process takes a couple of weeks. The tumor cavity also stabilizes after approximately 2 to 3 weeks. So that is the point at which we usually intervene with radiosurgery. And so that brings me to the next point, which is basically we have this 2-week rule. We use 2 weeks from the time of surgery to plan radiosurgery. 3 weeks is also appropriate. And we also try to deliver treatment within 2 weeks of the MRI. So once we get the planning MRI, which is 2 weeks after surgery, we try to deliver treatment within 2 weeks, ideally much sooner. But there's several retrospective papers that suggest that if the gap between the planning MRI and the radiation delivery is more than 2 weeks, your control with radiosurgery can diminish in the case of brain metastases significantly. This is not necessarily the case in benign tumors, where maybe 3 to 4 week gap is okay as well. So what you can immediately notice compared to the pre-op is that on both T1 and T2 scans, you can see that the cavity is smaller compared to the immediate post-op scan. And that allows us to deliver radiosurgery with less toxicity because the target will be smaller. Now, what I will also try to do, and this is, so I think brain cavity radiosurgery is probably the trickiest radiosurgery common case in the brain. Many trials have shown increased risk of local failure after brain radiosurgery. And there's a couple of reasons why when we come to planning and contouring. I guess firstly, I can ask how many people commonly treat brain metastasis cavities? You can either raise your hand or comment. How many people see this sort of case?
I don't think many institutions,
Okay.
but what I heard is many of them are interested in that.
Yeah.
They are in low and middle income countries, maybe Egypt, I don't know, but I know Uganda, Guatemala, and Mongolia, they have not treated radiosurgery, but definitely they
Okay.
are interested in that, yeah.
And how many people would give something like whole brain for this kind of case or some kind of fractionated radiation?
Do we have radiation oncologists here? I guess we do.
The reason I'm asking, I'm just curious what kind of, okay, yeah. So we have a couple people who could give whole brain radiation after this. So generally speaking, after a brain tumor resection for cancer, for metastases, if we don't do anything for this patient, the patient will likely have at least a 70% or more chance of the tumor coming back in the brain. So we want to try to do something. One alternative would be whole brain radiation, but many randomized trials have shown even after cavity resection or after tumor resection, that whole brain radiation increases the risk of cognitive problems, meaning patients will have memory problems or attention problems after whole brain radiation. So this is a case where I would prefer radiosurgery. When it comes to contouring, a lot of people will contour something like this, okay? And then target that with their radiosurgery dose. However, that's not really a great contour. What we want to do is include at least 2 millimeters of the rim of tissue around what we see as fluid. So something like this is a better contour. And this includes also the areas of the folds within the brain parenchyma that resolve after the resection. So you can see there's a big gap here, but once 2 weeks pass, you can see some of this folds into itself. And that's why a T2 is very important. On the T1, if we only use the T1 contrast scan, we might miss that area of fold that was down here. But we can't really see very well on the T1 contrast scan. So especially with cavity radiosurgery, having a T2 scan is very important. So this is, and we can look at some of these plans in the treatment planning system, either after each case or maybe afterwards if we have time. But this is sort of the general concept. So this is my target. I delineated that in red. And you can see it follows a 2 millimeter rim around the cavity and includes any residual enhancement. This enhancement might be blood product. It might be residual tumor, although that is less likely. But you can see in all 3 planes, there's a generous 2 millimeter rim all the way around the cavity, and that is designated as my target. My prescription dose was 27 gray. And you can see that that is beyond the immediate target, because with the LINAC approach, I do use this 1 millimeter PTV margin, which you can see maybe in light orange around the red target. And then that is prescribed 27 gray in 3 fractions. So now the question, why use 3 fractions? So for the longest time, we used to use single fraction radiosurgery doses. So this would also be treated in 1 fraction. That is still an acceptable alternative, and we'll look at what dose we can use if we treat in 1 fraction, especially if the patient is traveling from a long distance. So actually, when I worked at UPMC, we did have patients traveling 100 miles or more just to get their radiosurgery, and they were not able to stay in the cancer center area. So we still treated with 1 fraction. There is retrospective evidence that for cavities, the tumor control is better with 3 fractions or 5, as we can see, and the toxicity is less with 3 or 5 fraction radiosurgery. So that is why for patients who can stay in the area, and if there's enough machine time available, then 3 fraction radiosurgery does make sense. All right.
Excuse me, doctor. So
Yes, go ahead.
the three fraction, is it daily? How often do you treat? Is it once per week? How do you fractionate it?
Correct. So we're going to talk a little bit about the doses and fractionations, but to answer that question, you can do it daily fractions, no problem. I would say the largest retrospective series, and I believe the current randomized trial that is comparing 1 versus 3 fractions allows for daily treatment of the fractions. There's other sites in the body that maybe other physicians will talk about where we may prefer at least every other day fractionation, but in the brain, daily fractionation is perfectly acceptable. Okay, so this is some information from the latest Alliance trial on cavity radiosurgery. There's a very complicated approach for single fraction radiosurgery, where we measure the GTV, or the target volume essentially, prior to the addition of the PTV. So depending on the number of cc's we have, we use anywhere from 14 to 20 gray to the margin of the target. It's much easier if you do fractionated radiosurgery. That uses 27 gray in 3 fractions as the preferred approach. I use 27 gray in 3 fractions for almost all of my cavities, but the Alliance trial recommends that if the lesion of the cavity target is greater than 30 cc's, to actually use even more fractions, which is 30 gray in 5 fractions. There's no clear evidence that this improves outcomes beyond 3 fractions, but that is what the current protocol recommends. For intact brain metastases, and I will show a case of that, we use 21 gray for anything less than 2 centimeters in diameter. And the dosing for this is all over the map. You'll see some places recommend 24 gray, some places recommend 18 gray. But 21 gray has a decent amount of evidence, and that is approximately what is the national guidelines here for any tumor less than 2 centimeters. For tumors that are greater than 2 centimeters in diameter, again, I start using fractionated radiation, the same 27 gray in 3 fractions. This is actually a very good fractionation. If there's one fractionation you could use in any patient for radiosurgery, it is actually 27 gray in 3 fractions. When evaluating the plan, which I didn't really show in this particular case, but you can imagine that this plan is pretty conformal. You want the volume of the 27 gray line, this blue line, should be within 1.2 times the volume of the target. And in this case, the target is the PTV, which is the light orange line. So that is called the conformity index, and that volume ratio between the prescription isodose volume and the target volume needs to be between 1 and 2, and preferably between 1 and 1.2. Less than 1 means you're not covering the whole target, so it's always going to be bigger than 1, and it should be 1.2 at preferably maximally. In terms of coverage, I prefer 98% coverage with 120 to 140% hotspot. In our case, in the cavity radiosurgery case, we usually don't really care about the hotspot too much because that will be in the middle of fluid. But generally speaking, we have 120 to 140% hotspot for LINAC-based approaches. Obviously, for gamma knife-based approach, that will be a little bit higher. 95% coverage is probably reasonable as well. And the protocols actually, for a PTV coverage, allow as low as 90%. That would only be acceptable in the case where you have a critical organ next to the target that you're trying to spare. And so these are some notes on normal tissues and critical structures, again, from the same protocol. These have varied over time, but this is kind of the standard that we have settled in on North American trials. The optic pathway for single fraction radiosurgery should have a max dose less than 9 gray. And most centers here use 0.03 cc's as the max dose constraint. So it's not a voxel-based dose to 1 point. It is the 0.03 cc volume. And that's what's kind of the ICRU reported dose as well. So 9 gray to the optics. For the brainstem, we don't use a maximum dose constraint for radiosurgery. We actually use a 1 cc constraint because a lot of targets will be abutting the brainstem. They will be close to or abutting or within the brainstem. Even tumors or brain metastases within the brainstem may be appropriate for radiosurgery. So as such, brainstem, after you exclude the target, 1 cc of the brainstem should not exceed 12 gray. The same thing is true of 3 and 5 fraction constraints. There's, 0.03 cc's should be 17.4 gray or 23 gray on the optic nerves. And then the brainstem here is 0.5 cc as opposed to 1 cc. To be honest, I like to use 0.5 cc for all of these numbers. 12 gray for single fraction, 18 gray for 3 fraction, and 23 gray for 5 fraction approach. They do have maximum dose constraints, but again, for brainstem, I don't really use that. I use the volumetric constraint. Now, if you have tumor target and brainstem or optic nerves in very close proximity, I think it's a good idea to reconsider, should this patient get surgery? Should this patient get a different approach from radiosurgery? If we still feel that radiosurgery is the best approach, you can, on a very careful case-by-case basis, increase the maximum dose to optics to 12 gray or 19.5 or 25 gray in 3 to 5 fractions. And the brainstem 1 cc can get up to 14 gray. And these are the fractionated doses as well. However, I think that's a very case-by-case basis, and this falls under the variation acceptable under the protocol, but the recommended doses are what is originally printed here. Any questions about that, about those particular coverage goals and constraints? Okay. The other comment I will make is that you will hear a lot of centers talk about brain V12 for single fraction radiosurgery, or the equivalent in 3 and 5 fraction is V20 and V24. Usually the constraint that is used is a V12 or V12 equivalent less than 10 cc's. The protocols and national guidelines do not routinely include this variable, and that's for a couple of reasons. First of all, it's not clear where the cutoff should be. Should it be 5 cc's? Should it be 8 cc's? Should it be 10 cc's? And so we don't have a clear cutoff, although I do look at this number and I prefer it to be less than 10 cc's for a single fraction radiosurgery dose. Secondly, because we have these volume guidelines and these diameter guidelines, that automatically sort of takes into account how much normal brain tissue is going to get this high amount of dose. And then thirdly, there's a confusion about what to do with these doses if you have more than one target in the brain. So if there's 6 brain metastases and we're planning radiosurgery to all of them, then how are we going to, basically take into account brain V12? Is it by target or is it global V12? And there's no consensus on that. However, this is an area of investigation, and most treating physicians will prefer a V12 less than 10 cc's of the brain, or the equivalent V20 and V24 if we're doing a 3 or 5 fraction approach, to be less than 20 cc's. The risk of radiation necrosis or brain injury, which we call radiation necrosis, after radiosurgery increases with increasing volume. But you can see that with 3 fraction or 5 fraction approaches, as the volume increases, the risk does not increase too much. But if we do that with a single fraction approach, once we hit 20 cc's, we're already at a 40% risk of significant radiation necrosis. So I want to also kind of basically consider another case that's a little bit more complicated, but I want to share my screen here. So this is another case. However, this kind of illustrates multiple metastases and how we plan it. Maybe Dr. Sun will also go over some of the guidelines for how to plan this from a physics perspective. So here I'm going to show the MRI registration. Again, this is the non-high resolution MRI, and then we have the high resolution MRI. I'm going to turn the dose off for now just to show how these tumor look on the MRI. So you can see that there's multiple tumors in this for this patient, including one that's a little bit larger right here. And this maximum diameter is actually greater than 2 centimeters. So as I mentioned before, for any patient who has a tumor with the maximum diameter greater than 2 centimeters, I like to use 9 gray times 3 fractions. Now the question becomes, if I'm going to use 9 gray times 3 fractions, for these smaller tumors, do I do 21 gray? Or do I also do 9 gray times 3 fractions? You can see this one here. You can see one in the left frontal, a smaller one in the left frontal lobe right here. Right, there's one on the right side down here. And then another very challenging tumor in this particular patient's case was this pons tumor right here in the middle of the pons. So again, the question is, there's one tumor that requires or is preferred to be treated with 9 gray times 3 fractions. What do we do with the rest of these tumors? Now, because with a variant system and many other LINAC-based systems, we can use a single isocenter to treat multiple metastases at the same time. That means it's easier to treat all of them with the same number of fractions rather than having a separate plan just for this tumor up here for 9 gray times 3 fractions. So again, I'll repeat that. Because you can treat many metastases with a single isocenter with a single plan, instead of having a separate plan for this lesion, I have one plan with one isocenter, 1 or 2 isocenters that treats all these 5 metastases at once. Okay, and all of them will be getting 9 gray times 3, with the exception of this pons lesion right here. The pons lesion, I did not use 9 gray times 3. The reason for that is because our brainstem constraint was not being met, which is the 0.5 cc less than 19 gray or so. That was not being met if I did 27 gray, but it was being met with the 24 gray. So you can see for the brainstem lesion, I did not add a 1 millimeter margin. Okay. For all of the other lesions, I basically added a 1 millimeter margin just as.
So Dr. Siddiqui, so you still need 2 plans, right? For this case, or just 1 plan?
This case required 2 plans. Yes,
Okay.
there are many cases which require only 1 plan, but this case required 2 isocenters. That's correct. So if we look at the isocenter grouping, you see there's 1 isocenter group here and 1 here. So you can see there's a shift in the isocenter, and each one of them has multiple arcs to treat the patient. And then finally, I'll quickly show here sort of the PTVs, which again, 1 millimeter expansion. You can see one of these PTVs is not like the others, everything else getting 27 gray. This one PTV in the pons is getting a 24 gray dose, but it's getting 100% of the volume at 24 gray. Okay, so that's, and then we can look again at the brainstem, make sure that we understand a brainstem dose. So you can see the 1 cc dose here. I will convert this to absolute volume. Let me open up the brainstem separately. And I like to look at brainstem minus the target. So here you can see the label as brainstem minus PTV5. We did not add a margin, you can remember. So the 0.5 cc dose is about 19. Let's see here. It's about 19 gray. So if we remember from the presentation, the 3 fraction constraint was 18. So I exceeded it by a little bit, but 19, or excuse me, 24, up to 24 gray was allowed by the protocol. So this is just above the preferred dose, but still within the 19 to 20 gray that we prefer for the 0.5 cc of normal brain. You can see the structure excludes the target here. You can see how I made a Boolean that excludes the target in the structure. And then in this particular case, there was no real concern for the optic structures because they were not very close by. The chiasm and the optic nerves are here. And we can sort of see that all of them are well under 9 gray. So the maximum dose was to the chiasm, and that was You know, if we scroll to the 0.03 cc dose, that is about 6 gray, which is well under 9 gray. Okay, so this case illustrates many things: when to fractionate for intact brain mets, what to do for a brainstem lesion, and again, you sometimes treat these with single fraction radiosurgery as well. But most investigators, most treating physicians will not add a margin, PTV margin, like we would for LINAC-based radiosurgery to targets outside of the brainstem. So this is all sort of illustrated by this case. Any questions? I know there's a lot being said in this case. And in this particular case, T2 MRI is not necessary because all of these lesions are intact. All right. Well, we'll go back to the presentation again. Let me reshare the screen. And as a final case, before I hand it over to Dr. Sun, I just want to cover vestibular schwannoma case, okay? So why vestibular schwannoma? It's a relatively common tumor. It is a very difficult tumor to treat with surgery. It requires significant expertise to have a good outcome with surgery. And so radiosurgery is a very, very attractive alternative to surgery for the appropriate patient. The other reason is that vestibular schwannoma is sort of a baseline case for many other skull-based lesions like meningioma and like pituitary adenoma, which are also very common and also can be treated with radiosurgery techniques with similar dose and similar constraint considerations. So this is a patient I treated recently. They usually present with unilateral hearing loss. So you see this is an audiogram showing that the right ear has a significant decrease in hearing compared to the left ear. You can see the decibels required to hear the pure tones in the 60 to 90 range. And quickly, what we also, let's see, we usually grade hearing as serviceable if it's class A or B, meaning that their pure tone average across 500 hertz, 1,000 hertz, 2,000, and 3,000 hertz is less than 50 decibels, so they can hear quiet tones, or they can discriminate speech at least 50% at those frequencies. So we want to use both a pure tone test and a speech discrimination test ideally, and you have the 50-50 rule for patients who have hearing intact. Now, there's a grading for vestibular schwannomas, which can be helpful. So you can see Coos grade 1 is if the tumor does not expand beyond the petrous bone. Coos grade 2 is something that expands into the brainstem cistern but does not touch the brainstem. And Coos grade 3 touches the brainstem, and Coos grade 4 causes a deformation of the fourth ventricle or a significant deformation of the cerebellar peduncle or the brainstem. Now, again, when we go back to the principle of considering surgery first, this Coos grade 4 lesion does need to have surgery, generally speaking, but Coos grades 1, 2, and 3 may be treated appropriately by radiosurgery. I will also add that for Coos grade 1 lesions, observation is a very appropriate alternative. So not every patient with a Coos grade 1 lesion needs to have radiosurgery for treatment. The things that we consider for treatment are they already starting to lose hearing, and has the tumor grown over a couple of years? So if we get a repeat scan in 1 year, if a patient presents with such a small tumor and the tumor grows over 1 year by 1 millimeter, grows over 2 to 3 years by a couple of millimeters, then we know this patient may benefit from radiosurgery so that they can preserve the remainder of their hearing and also not get additional neurological side effects if it continues to grow to a Coos grade 3. For Coos grade 2 and grade 3 tumors, I think right away considering radiosurgery approach is very appropriate. You can see that in the Coos grade 3, we have this abutment of the brainstem, okay, and that kind of help is something that needs to be highlighted during planning. So in my patient, she had a Coos grade 1 still. It was almost becoming a 2, but it had shown interval growth year over year. So after her original audiogram, she had a 1-year follow-up MRI, and there was about 1 millimeter of growth in this direction, in the transverse direction, and about a couple, a millimeter of growth in the Z direction, which I'm not showing here. So this patient's tumor grew. Her hearing was already not really serviceable, so we weren't necessarily hoping to preserve her hearing, but we wanted to prevent further growth. Okay, and this is how the tumor looked on T1 contrast MP-RAGE imaging. This is kind of the plan, and I will quickly, I guess, probably the easiest is to quickly show this plan again in our planning system. And I want to also highlight, so for skull-based lesions, and the specific T2 sequence that we obtain is called the CISS, Continuous Interference Steady State. It highlights the cistern very brightly, and you can see the cranial nerves at a very high resolution and the vessels. So you can see, for example, cranial nerve 5 right here on the other side and on this side, and then you can see this tumor very easily. So we fuse both the CISS T2 image, which is a volumetric acquisition, as well as basically the T1 contrast image. And you can see I use all of these to make my GTV. One other thing I want to point out, this is a very subtle point, but usually in the canal, there's an area on, there's an area that seems like, let me turn the dose off here. There's this area that seems like it might be tumor, but on the T2 sequence, it's actually just fluid. You can see it's actually fluid right here. There's a fluid cap at the end of the schwannoma, and it's important to avoid treating that so that we don't increase the dose to the cochlea too much. So the typical dose is 12 to 13 gray for almost any skull-based lesion. I chose to go with 12 gray. You can see that the GTV target itself is probably getting around 14 gray, whereas the PTV is getting given 12 gray. And the only other thing I will highlight here is this cochlea. This is a skull-based constraint that's unique. Usually we don't look at the cochlea dose routinely, but it's important to look at it if you have a temporal metastasis up here or you have a skull-based lesion. And we try to keep the mean dose to the cochlea less than 4 gray. Here you can see that the brainstem dose is a budding 12 gray, and the volume of getting half a cc is less than 12 gray. Okay, so we'll go back and finish the last few slides of the presentation before handing it off. Okay, so yeah, again, this is sort of the T2. So for follow-up, I get a follow-up every 3 months with a high-resolution MRI, the same technique preferably that you use for treatment planning. For metastases, 6 to 12 months would be okay for benign tumor. Clinical exam, you have to be on alert for adverse radiation effects and necrosis. For example, in a schwannoma, people can start getting dizzy or lose their hearing acutely within a couple of weeks after radiosurgery, and you want to try steroids for that. Alternatively, people can have, for brain metastases, other side effects like headache, and you want to be quick about adding steroids on board if you have not already. There's a controversy for whether to add steroids. Usually we treat with about 1 to 2 days of steroids, dexamethasone 4 milligrams BID, for every radiosurgery patient prophylactically during the radiosurgery course. If they get another round of symptoms, depending on how severe it is and what the imaging shows, we can try steroids again, or try intravenous Avastin or resection of the area of necrosis. And another thing is that new metastases that are seen can be treated with radiosurgery pretty effectively, usually. Okay, with that, I will hand it back over to Dr. Sun if there are no other questions.
Actually, there are a few questions in the chat.
Okay.
So Dr. Siddiqui, maybe starting with Minjima from Mongolia. Repeated treatment is always complicated. If patient had RT to the same brain area before, would you treat with SRS if those constraints exist?
Okay, yeah, great question, Minjima. I think what we would do, so the only area that I'm very careful with is the optic structures, optic nerve and optic chiasm. If those structures already got the maximum dose, then and another tumor appears in the same region, then you might be a little bit hesitant to do radiosurgery. Everything else, it is unlikely that the new tumor pops up overlapping with the same tumor. So you can always treat new tumors with radiosurgery, in my experience. Very rarely you cannot do it with new tumors. If the same tumor grows back, that is probably the most complicated scenario. And in that case, I usually do fractionation, like 5 fractions, or surgery. You try to do surgery, a surgical approach. And then there was another question.
What's the smallest size of brain mets we can treat with the SRS?
Yeah, so we treat almost any metastases that we can see on MRI. It sort of is limited by MRI resolution. What I didn't emphasize, and maybe Dr. Sun will, it's very important to have very good acquisition of MRI and registration for planning. And also it depends on the immobilization of the patient. So if you have basic mask-based immobilization, then you might want to not treat very small lesions, especially with a single isocentered technique. If you have surface guidance and intrafraction tracking, then you can treat 1 to 2 millimeter lesions without a problem.
Yeah, I would probably, for these countries who has never treated brain mets or brain SRS, is starting with larger targets first. Once you get more experience, you understand uncertainty of immobilization, your MR resolution, then you can, gradually go to smaller size. That's my answer. I mean, here we can treat, a few millimeter size, even using physical cone or using the MLC. So it's all because we have done so many. So that's another question, Dr. Siddiqui. CC from UCI asked if they don't, for many low and middle income countries, the MR planning is not easily available. And, they're based on CT, what's the challenge,
Yeah, so in fact, I have treated patients with CT only as well. There are some of our patients who have shrapnel or some other metal implants in their body. A CT-based approach is fine. You have to remember we can only see a brain metastasis on CT with contrast if it's usually above 5 millimeters in size and diameter. Below that, you might be able to see it, but you can't target it necessarily well. So you would probably have to continue to observe the patient until it's at least 5 millimeter in diameter. But the principles are the same. You would get your high resolution. So the standard CT sequence, even the one that we get here, is not at 1 millimeter slice thickness. So we can try to use a sequence that's 1 millimeter or finer resolution, and then use a contrasted CT scan. And I would also keep with 1 millimeter diameter PTV, 1 millimeter expansion on the PTV, even for CT-based planning.
Okay, I will continue my presentation here. Let me see. You can see my screen, right? Let me see.
Yeah.
Screen. Hold on.